morning, everybody. Welcome to Georgia Heart Grand Rounds. It's great to see you all this morning. Thank you for joining us today. This program is brought to you by Georgia Heart Institute. The planners have disclosed no relevant financial relationships with commercial interests. Dr. Rinfret will disclose his in his presentation. Please scan the QR code to sign in for your attendance. Please also remember to take our evaluation, which will be shared with you at the end of the presentation. If you are virtual, these links will be placed into the chat. And now it is my pleasure to invite Dr. Egelum to introduce Dr. Rinfret.
Hey, good morning, everyone. It gives me the esteemed pleasure to introduce Dr. Rinfret, who is already known to most of you. But he spent over 20 years serving patients and students. He's internationally renowned and known for his academic and clinical skills. And he's written a textbook named Percutaneous Coronary Intervention for Chronic Total Occlusion, as well as hundreds of published articles. He's a professor at the Emory University School of Medicine and previously worked as an interventional cardiologist at Emory St. Joe's Hospital System and also Emory University Hospital. He earned his medical degree at the University of Montreal, where he completed residencies in surgery and internal medicine and a fellowship in cardiology. He also trained in interventional cardiology and research at the Montreal Heart Institute and at the Beth Israel Deaconess Medical Center. He earned a master's degree in clinical epidemiology from the Harvard School of Public Health and been here in the capacity of our Director for Complex Coronary Disease. So it gives me the extreme pleasure to welcome Dr. Rinfret as he speaks to us about CTO. Thanks.
So good morning, everybody. It's a real pleasure, and it's been a great pleasure for me to work in this institution, both for the pleasure working in this cath lab that is like absolutely fantastic in terms of cath lab staff and setup and devotion to the best of what can be done to the patients. And I'm very privileged to be able to talk to you this morning about what really passions me in this in interventional cardiology and where we have opportunities to grow, especially in this population here, which is quite diseased. These are my disclosures that are basically all companies making tools for interventional cardiology. So today we're going to discuss about the long-term revascularization strategies in coronary disease, touch a bit on the saphenous vein graft disease post-CABG, discuss about the effectiveness of CABG itself to treat a CTO, the effect of CABG on the native circulation, and the current strategies on post-CABG patient with SVG disease. So it is more a pragmatic assessment of current strategies and what can be done to improve outcomes and quality of life in patients with coronary disease in their whole the whole life of the patient. It's not about surgery or PCI. You'll see I'll bring this sort of debate throughout the presentation. But we know CABG and PCI have there's a balance of opportunities and advantages with CABG and PCI. On the side of PCI, the applicability, the ability to repeat, and the invasiveness will certainly play in favor of PCI, whereas the durability of the initial result and the longer-term outcomes have always been a bit favorable for CABG. But if you look at the latest meta-analysis of CABG and PCI trials, this is the best study that's still a bit old, but there hasn't been any studies since comparing PCI and CABG. You look at these patients; they had on average a relatively good LV function. In the PCI group, they had a large proportion of bare metal stent, which we don't do anymore, or first-generation stent. And the CABG procedure involved up to 28% non-lima. So bilateral lima was off. It was used in 18%. And despite this, when you look up to 5 years, when you don't have diabetes, there's no difference in terms of mortality. When you have diabetes, so surgery seems to have an advantage up to 5 years. And the same story, if you have a 3-vessel disease and you don't have a left main, it seems to be an advantage of CABG, but not for left main strategies. And you can see here up to 5 years, no difference in terms of mortality. Well, however, it seems that the curves seems to diverge a bit after 1 to 5 years, but still no real difference. The key outcome of that meta-analysis showed that with CABG, seems to be that you're going to have less spontaneous MI. So that is something that is important to realize, especially on the first 5 years. However, there's going to be more strokes and, however, less repeat revascularization. There's another study here where they looked at the very long-term outcomes of the Syntax trial. The Syntax trial was a randomized trial comparing PCI to CABG. And when you look at PCI and CABG group in terms of mortality, it's exactly the same. And they overlap from 0 to 5 years and 5 to 10 years. However, when you try to dissect again by 3-vessel disease or diabetes, in that study, diabetes didn't make a difference. However, there was a slight improvement of survival, which didn't reach significance, but with the 3-vessel disease over the left main with CABG. But with left main, no difference. The Syntax score is a well-known score where you actually look at the coronaries, and the more complex the coronary disease is, the least least benefit you will gain from PCI. And this is actually seen here in the score more than 33, seemed that CABG had an advantage. So one of the problems with all of these trials is that although diabetes and complexities favors the management of CABG for improved outcomes, about less than 20% of all the screened patients were actually randomized in these studies. And we don't really have data beyond the 10-year time point. And we know that up to 50% of the SVGs will be closed at 10 years. And the life expectancy of patients is definitely longer than their vein graft. And does it have really an impact on the longer-term outcomes? So beyond left main and 3-vessel disease, we don't know much from those trials. The presence of a CTO is a real dominant reason to refer for CABG instead of PCI, and this is not really known in these trials. The Syntax score does not capture the full complexity of the patient, including the morbidities, and also the residual Syntax score was not really considered. What is the residual Syntax score? How did the surgeon and the interventional cardiologist do their job? Did they really perform complete revascularization? The studies were also with older stents, low proportion of optimal imaging PCI, and the fact that PCI post-CABG is difficult. PCI of SVGs is not really good in terms of outcomes, and PCI of natives following CTOs is difficult, and I will go through this. From a patient perspective, patients often say that they want to live longer and live better, but when you look, there's a very interesting study of close to 4,000 patient caregiver preference, and what they say is that they want to improve their quality of life, and this is really what is the most important value of most patients. Quality of life incorporates a lot of things, non-fatal MI, strokes, new AF, anticoagulation, progression of CKD, a lot of things that will come in play. We've all gone through this. When you refer a patient to CABG, sometimes it's taken from the patient as a bad outcome. It's almost like I could come to the patient and say, you're gonna have a heart attack. And you tell them we're gonna have to do a bypass. You see that they're like, am I too sick to have stents? You cannot do it. Sometimes you have to say, it's not because I cannot do it, it's because it's gonna be better for them. But still, it's still perceived, I'm still looking for that patient who's gonna say, yeah, I'm going for CABG. Never happens. They know it's a big deal, and that is something that we need to be thinking about. What about the quality of life after PCI or CABG? There's many ways to measure quality of life. Maybe when you look, initially there's an advantage in terms of how patients feel with PCI. Of course, if you look over the first 6 months, seems to be better, but on the longer term, they equalize. So there's a big toll to pay at the beginning, but in favor of CABG, after some time, they gain their quality of life equal to what would be expected with PCI. But it's a rougher first year, and we all know this. So if you look at the mental component as well, these patients don't do good until they reach up to about 3 years and they feel better because it's a rough time for them. So the reality is that, and in the end, what are we talking about here? It's like the reality is that most coronary disease patients will need PCI during their life, will be either without CABG, pre-CABG, and post-CABG. Does the choice of the first strategy matter? And in practice, we know that there are clear surgical cases, there are clear PCI cases, and some that could be treated both ways. But I think it's the minority of patients that we could see would be treated in both ways. But in the end, all patients will need PCI one day, sooner or later, and a lot will need CABG. The reality, however, is that when we're dealing with how we do CABG, the vein graft is that it's still the most employed type of conduit in the world. 50% will be occluded within the first 10 years, and we know that it's a combination of early dysfunction for the first month. Then the acute phase is more like neo-intimal formation like restenosis for the 0 to 1 year. And then afterward, they become atherosclerotic. The 1 year occlusion rate varies from 10 to 40%, but roughly around 15%. So all the bypasses that are placed, especially vein graft, at 1 year, there's 1 out of 5 that will be closed. And afterward, you can expect about 2% per year for the first 5 years, and then 5 to 12. And we'll see how it impacted the result of the recent trial. The RAS trial was a very interesting study. It was done, led by a Canadian investigator, a surgeon, randomized either radial to SVGs. And what they did a systematic angiogram 1 year later. And what they found is that the saphenous vein graft added 13%, like a 14% occlusion in 1 year compared to 8% with the radial. However, the radial also had what we call the string sign. So when you add these two, it's about 15% dysfunction at 1 year, either a radial graft or a vein graft. The advantage of the radial graft is after the 1 year, it stays. There's no loss of radial graft, whereas there's going to be additional loss of vein graft. So I want to start with a case here. This is a 70-year-old male, hypertensive, no diabetes. He had a non-STEMI in October 2017, and he had 3 vessel disease, and here's what he was managed. I'll show you the angiogram. He's got pretty bad calcified nodule at the osum of the LAD, long calcified OM stenosis. There's 2 large OMs, a very nice distal target of the LAD. So you see that these 2 OMs, like an anterior branch and posterior branch, are quite big. And then you see that there's an RC CTO and there are collaterals coming from the left system. So appropriately, with the syntax score of this guy, he was referred for CABG. So he went on Pomlima to LAD, vein graft to these 2 OMs, and then vein graft to the RC. So 4 years later, he's back with angina. And he's got an infralateral ischemia, and a CAT is done in the outside hospital, and that's what we find. You see that progression of the proximal lesion 4 years later. And there's a new occlusion of the OM. So there was an OM giving 2 branches. Now this vessel is occluded. We've got a patent IMA, which is almost invariably the case. We've got an heavily calcified CTO and an occluded vein graft. And the posterior OM and the anterior OM graft is gone. So the question that you have to ask yourself is, first of all, has the SVG to the RCA CTO territory ever been patent? The distal target was very remodeled. And is the circumflex and the LAD progression, we have like new occlusion, the result of spontaneous event, prevented by the CABG or the result of CABG? And that's what I want to start in our discussion. When we talk about CABG for CTO vessel, we know that the presence of a CTO is a very, very strong predictor of how the patient will be managed. If you have no CTO, there's a bigger proportion of patients with 3 vessel gonna get PCI. If you have a CTO, they're gonna go to CABG. And we discussed this in a review article, and I think it is the belief that incomplete revascularization, especially with PCI, would lead to increased mortality, and that CABG achieve maybe more reliable CTO revascularization. The reality is that if you look at, this is a large registry where they actually did sort of an ecologic follow-up of patient going through cath lab and what was done with these patients. Not really a real interventional study, but they looked at how the patient were managed with their CTOs. So 15,000 coronary angiogram, and they found overall with patients who have coronary disease that 1 out of 5 patients have a CTO. However, if you look at the post-CABG, 50%, so half of the patient have a CTO. So why is that? Well, also, and how were these patients managed? You can see that in the group that had PCI of the CTO, only 70% success. And when they grafted, you will see we'll be coming back to this afterward, they had a very poor, actually, success in bypassing with about 11% of patients that never got a graft. And why is that? It's because CTOs lead to very important negative remodeling. These are 2 studies that showed that actually, when you reopen the CTO, the vessel distal can grow up to 400%. So the vessel is shrunk because it's filled with collateral, and to maintain perfusion pressure, the vessel is shrunk. This is a very nice example from a friend in France who showed me this is an LED CTO. He opened up the vessel and he was a bit disappointed. But they have the luxury in this, case to be in a registry where they brought the patient back. Patient is doing fine, but this is how the LED looks 4 months later. So had the patient been referred for CABG, this vessel was barely graftable. It would have been a very negatively remodeled vessel. So, and we have very limited data on the graftability of CTO vessel, which is the ability of the surgeon to graft the vessel, and the long-term patency of the CABG by the type of graft on a CTO vessel itself. Remember, we send patients for CABG because they have a CTO, but we want to know if they can graft the CTO, and how is the outcome once the CTO has been grafted. And the problem is that the negative remodeling is a big impairment to the performance of surgery in these cases. And again, in that Canadian CTO registry, 26% of the patients were sent to CABG, but out of them, 11% of the CTOs were not grafted. So therefore, the surgeon looked at the vessel, said, I cannot attach a graft on it. This is the best data we can have is from small single center series, and they talk about surgical revascularization for CTOs, and you see there, I like this, their articles, what you see is what you get. And it's really a real pragmatic standpoint of a surgeon. He says so they had 43% of patients at CTOs, and they were able to graft the LED in 96% of the cases. But in the CIRC, 85%, and it goes down to 79% in the RCA. And the visibility and the grade of collateralization prior to surgery was not predicting how they could perform the surgery. In 156 cases where they looked at grafting the RCA with a vein graft, whether it was a CTO or a stenosed vessel, they were able to graft the RCA 81% of the time when it's a stenosed, like a 90-95% lesion. It's got antegrade flow, but when it's collateral flow, only 40% of the cases were able to be grafted. And this is not surprising. This is something that we see all the time. This is the syntax trial. I told you it's a randomized study of CABG and PCI. And there were some patients who had occlusions in their coronaries at the time. So this is the group of patients who had occlusion and they had 3 vessel disease. Let's look at how they did with PCI. So the ones randomized to PCI, they were about 50% that had a successful reopening, and 40%, like maybe almost 50%, they failed reopening the vessel. Not really good. And because there were some total occlusion, but they didn't do really good. What I think is important to look at the surgical arm. Of the ones sent to CABG, 32% of the totally occluded vessel were not grafted. And when they looked at the CRF and look at what the surgeon said, he said, I didn't have the intention to graft in 12. It was a diseased vessel in 12, inadequate conduit in 2, insignificant vessel in 19, so which means it's a remodel. I cannot see anything. Does it matter? It does. Because irrespective of if you're managed with PCI or CABG, when they look at the longer-term outcomes of these patients, you have a better outcome if you have a complete revascularization, either with PCI or CABG. Incomplete revascularization is associated with worse outcomes. We have a study where they looked at the fate of the graft 1 year later. So I told you that about 20 to 30% of patients referred to CABG, they will not have their vessel grafted out of the CABG. What happens if they have a graft on their vessel? That's what that study looked at. And because they graft a vessel that's remodeled, it may affect the long-term outcomes. And what they found in this study is that only 25% of graft placed on the RCA and other vessel graft were still open. On the LAD was really good. When they used the Lima on an occluded LAD, it was good. But anything else was not really good. When you look at the 1 year outcome in the RASP trial, if you look at the more than 90% stenosis, there's no difference, but we don't have any data here in that study about the CTOs. So we don't know. They're all severe lesions, but the 100% we don't know. But we know, however, that the smaller the vessel, the lower the patency on the long term. This is a very interesting study. So they looked at outcomes of CTO patient, whether they were managed with PCI or CABG. And interestingly, the worst group on the long term was the medical therapy of the patient with CTOs. But also, if you look here, this is patient who had CTO PCI. This is a failed CTO PCI here, and this is the CABG. The CABG group, they didn't look at if they CABG the CTO itself, but the CABG group was doing in between a successful CTO PCI and a medical therapy. Could be a lot of biases here. I want to go on with this study. This is the study I showed you about the ecologic, whatever treatment they were doing with CTOs in 3 Canadian centers. The beauty of that study is they looked out to 10 years, and they looked at what was done to the CTO vessel itself. And when they look at the CTO revascularization, there's a reduction in mortality up to 10 years compared to no CTO revascularization. And again, we will never have a randomized trial showing this. And we say all the time, CTO PCI is only for symptoms. Problem is that to demonstrate an improvement in survival, we would need a 8,000 trial study with patients who are symptomatic and they will never want to be into these studies. I truly believe that we actually can improve survival with CTO PCI, but I have to say that it's only observational data. When you look at CTO by grafting of the CTO or opening the CTO, that's where it's super interesting. Look at the CABG and no CTO grafting. They do like the same as medication. But look at CABG and they grafted the CTO, they do like CTO PCI on the long term. So it's very important that actually the surgeon cares about doing the CTO when he's grafting the patient. So this is something that is very interesting. So in summary, CABG does not work by intent to treat. It's not like a randomized study. There can't be a placebo effect here. The vessel needs to be grafted. The presence of a CTO is a major driver of selecting CABG, I told you. When a CTO vessel is successfully grafted, the graft remains patent. The benefits are similar to post-CTO PCI. However, as I told you, there's a large proportion, from 20 to 60%, depending on the vessel, that of CTOs that will never get grafted. And it's likely because of severe remodeling. It is unlikely to be surgeon dependent. There's so much that a surgeon can do on a vessel that looks like a crappy vessel on the table. And I want to remember that in experienced hands, you can achieve revascularization over 85% of these CTOs. And when an SVG is placed on an RCA on a CIRC, 1 year patency may be much lower than in non-CTO vessel. So I talked to you about CABG to treat a CTO. What about CABG as a cause of CTO? Well, this is a study where they looked at the proportion of patients going to the study that I showed you earlier about going to angiography. 54% of patients, they had a CTO when they were post-CABG, and 20% had a CTO if they hadn't had CABG. And the reason why is that because CABG caused CTO. CABG is the most potent reason for causing a complete total occlusion of a vessel. So this is in that study where they look at the fate of the coronary disease. So they did CABG, and they look at the native coronary disease 1 year later. So at the time of surgery, about 20% CTOs in the LADs and 40% occlusion in the right. And then when they look 1 year later, 20% more occlusions. And the big question you have is, why is this? Why is CABG associated with so much more occlusions? And we'll go back to this. The new CTOs were more common with the less common with the IMA, but more common with severe stenosis. So when you had a severe stenosis here, you can see that in 90% of the cases, when you had a 90% stenosis on the lesion, that lesion would become an occlusion. And I want to just discuss something that is sort of a fallacy, but it needs to be debunked. So the concept of bypassing plaque instability. And I would like to hear any other opponent comments on this, but it's always quoted as the benefit of cardiac surgery. It's like, because you put a graft on a vessel, it's really why CABG works over PCI. I don't deny that CABG has an advantage over PCI in some patients, but I don't think it is the mechanism, because, so they say the coronary is bypassed by a graft that is not diseased. So therefore, the coronary disease, the plaque is not a threat to the vessel anymore. And then if there's a spontaneous plaque that happens proximal, the vessel is protected by the graft. So that's what has been said for a long, long time. It is not really what's happening. It's competitive flow. So this is what's happening when you have stenosis here, you've got bypasses. What's going to happen is these vessels will occlude because of competitive flow. It is not a spontaneous event. And what's going to happen, the graft will become diseased, and at some point, the graft will occlude, and what's going to happen, collaterals will build to the vessel, and then we have a post-CABG typical patient 10 years later. What is the natural history of coronary disease? Is there any situation where in 1 year later, after anything we do, 20% of patients can have an occlusion of their coronaries? It doesn't exist. This is the prospect study where they looked at, you have a plaque, you have a severe plaque, and we look at what's the fate of that plaque over the year following. And they look at MACE, they did a very detailed analysis, and the 3-year cumulative event was 24%. But when you look at, the lesions were angiographically mild at baseline, but very important to look. The death from cardiac arrest and myocardial infarction was really, really low, okay? And when you look at the number of patients having events were relatively low. So the ones who had like a plaque burden more than 70% had 5 times the risk of having an event. But overall, when you look at the proportion of patients having an event, we're not talking about a complete occlusion. It was only in these ones who had everything in their plaque. So in terms of what it looked like over the 5 years, less than 5% absolute patient at an event at 3 years. We don't have all their angiograms, but if it had been an occlusion at 3 years, it would have been an event of, it would have been 20% STEMIs, which makes no sense. That to have like 20% occlusions additional a year later, that would have been spontaneous events. So the alternative explanation is that the progression of plaque proximal to the graft is no longer a spontaneous event, but it's a result of the competitive flow. The plaque progression occurs also distal to the graft, and we know that even in LED grafted to the lima. And an SVG that becomes atherosclerotic because of its length will offer a higher probability of vulnerable plaque over time. You're exchanging a plaque that is about 20 millimeter for a graft that's 10 centimeter. And this plaque, this SVG, in terms of probability, will be much more of a threat over time than the original graft. And so we're exchanging some disease proximal vessel by an, if you do by an arterial graft, then it's completely different because the arterial graft cannot become disease. So therefore you're eliminating the proximal issues, but not with a vein graft. And I want to come back and remind people that the modern DES long-term patency is way better than the vein graft, and we know that that they can be up to 90% at 10 years, even with the ciphers. What does predict the progression of coronary disease? Well, of SVG disease, unfortunately, there's not much we know beside cholesterol. Plaque stenosis, it is a very difficult to predict event. And this is usually what's happening. You've got a graft that you've got a native coronary, and then we put a graft there. So what's happening is that there's going to be native competitive flow distal to the native stenosis that will lead to an occlusion. As long as the graft is working, it's fine. But when the graft starts to be diseased and occludes, then we come with a situation where the left system, for example, in that right, will be doing collaterals. And of course, nowadays we can treat that. We can use the graft that's occluded, open the right, and put a stent. But the whole question is that, is this cycle optimal? Should CABG be used as late as possible with coronary disease? Patients often with 3 vessel in their 40s are sent for CABG. We expect that when they're gonna come in their 50s, they're gonna have this type of disease. I'm questioning if as long as the graftability is preserved with current technology, shouldn't we be giving a first shot to PCI? And the thing also is with complete arterial grafting, alleviate this cycle as well. And what does explain the slow uptake of complete arterial revascularization in young patients in the US? This is all the questions that I still have nowadays that are not answered. When you look at 7 years, a new CTO is not good for patient. They usually have cases where they're not treated, and this is also post-CABG. So in summary, the CTO as a consequence of CABG is that when you have a baseline stenosis over 90%, 50% of the grafted vessel, the native vessel, will be occluded. And I showed you that it is not a spontaneous event. Otherwise, it would be 20% STEMIs, and it makes no sense. And we also see left main occlusion, left main occlusions after bypass. I can tell you a left main occlusion as a spontaneous event, it's a death. So we see these after CABG, you never see these as a spontaneous event. When SVG becomes disease, there's a high likelihood that the natives will be a CTO, and new CTOs associated with more events. So what can we do to help these patients? And sometimes we decide we have no other choice. We decided to do CABG. Sometimes they've had PCI in their grafts. What we know is like PCI in the graft doesn't do good. It's the only substrate in all the lesions. They're talking about STEMIs, bifurcation, long lesion, large lesion, small lesions, left main. That's the only substrate where DES has no advantage over a BMS. You could put the BMS in the vein graft, and the outcomes at 2 years is the same. Why is that? It's because it's not lesion related. It's like the clock is ticking in that vein graft. It has nothing to do with where we are treating. And the event rate is 24% at 2 years, which is huge. This is a very interesting study by my good friend Manos Brilakis, who looked at ACC and CDR, and they looked at, and the VA, and they looked at the long-term outcomes if you're post-bypass, whether you're treated in your vein graft or you're treated in your native. And the outcomes of that MI revascularization was much better when you're treated in your native instead of the vein graft. This is a case that from last week, and actually the patient was discharged yesterday. So I'm not talking about stuff that we never see. We see that all the time. So that patient was 75-year-old, hypertension, hyperlipidemia, diabetes. And at the age of 58, she had a lima to LAD and SVG to a diag, and SVG to NOM, and SVG of RCA. And this is what she had over time. So starting in 2009, which is 2 years later, she had patent grafts. So something was probably happening because she was already having symptoms. But in 2013, she had PCI of an OM. 15, PCI of a diagonal. Chest pain, 16, SVG to an OM. Then she has ISR, the vein graft, in 2020. And then 22, PCI of the SVG, 24. And then she comes again with unstable angina, and she's cath. This is her cath. This is the circumflex. This is the right coronary, which is a CTO. You can see an old stent here that is under-deployed, but there's no flow going distal. This is the vein graft that has had multiple stents, and now it's gone. It's occluded. This is another vein graft that has some distal disease here to an OM, soon to be gone too, but it's still working. The lima, as always, is doing a fantastic job. But this is her vein graft now. And I want to show you that this is the reason the studies fail. Look at that beautiful stent right there. And at the time, there was no disease. On top, no significant disease. Now what we have a significant disease there, and we have an anastomotic lesion right there. So appropriately, it's a first failure post-PCI of the SVG. She has a lesion in the distal anastomosis, and then I'm consulted for treatment, and I thank my colleague, who's Vikram Rajay, to come to me and say, I don't think I'm gonna do the right thing here if I just go and stent again the vein graft. Is there something else we can do? I said, yes, we can do something better. And this is what we decided to do. This is 2 years later. You can see 2 days later. Sorry, she spent the weekend in the hospital. So you can see that the dual angiography shows that this is the distal, and we have to connect the dots. Connecting the dots is just technical thing. This is all something that can be learned by someone who has the will to learn it. The slow flow with the SVG, and basically I will go through this. We would try to stay in the old stent. It was difficult. We tried to cross the mid stent with a microcatheter. Couldn't work. We have new tools. We use the laser to make a little hole in there. And then afterward, what we're gonna do, we're gonna actually, sometimes CTO PCI needs a bit of gentle movement, but also sometimes a bit of brute force. And what we're doing here, we're using what we call the section reentry. So we're pushing wires, and we're actually reaching from the wall of the RV, the distal RCA. So now we're in the distal RCA, and we can see now that the flow is a bit reduced. So because I still have access to the RCA with the ballooning there, and then we're using a balloon that is from the wall of the artery, which is the media of the artery, and from this balloon, we're actually sticking into the true lumen right there to make a reentry into the vessel. And in that case here, you can see that we were able to come from this subintimal space to the posterolateral, and then used again another catheter, and we were able again to come into the other branch. So we were able to secure both branches, and after stenting, we got this result. We got a native artery open with 4 millimeter stents that had never been treated, okay? So why is post-CABG CTO more difficult? They're more calcified. And what is the pattern as well as we've done this in the study is that although the outcomes is very good, it's not as good as when you don't have a CTO. If I would prefer, a CABG. If I would prefer, it's always easier and better for the patient if they have a CTO PCI done and they never had CABG. But I would say, like the surgeon said, what you see is what you get. Here in that environment, and what the surgeons and what people are referring to me is a lot of post-CABG, and a lot to Dr. Henry and Falgun and Nima, is that we get a lot of post-CABG patients. And the reason why is that they have a lot of CTOs. They have a lot of challenges, these cases. They have multiple sources of collaterals. They often have LV dysfunction. They have risk of loculated tamponade. But they have also opportunities. The grafts can be used as retrograde pathways. We can use the patent or an occluded graft. We can use septal from the grafted LED. And sometimes I take the time with the staff to make a drawing, because it's very easy to get lost into grafts and where it's coming and why I want to go there and why I want to open this. But I think it's important to realize so what are these opportunities and what we can do. So this is a 14-year-old graft. Of course, someone can drop a stent in 5 seconds, maybe 2 minutes into the proximal SVG. However, the acute mortality risk is 1.5%. Would you choose your 1.5% to be on your CTO? Of course, because this can be used to go retrograde. That's the easiest retrograde you can do, and have your native being open. So these are the opportunities we can get. We were the first to look at the use of vein graft on the longer-term outcomes as retrograde conduits or retrograde approach. And it's the safest approach possible. When we can use a vein graft, an old vein graft, to reopen the native, it's safer than using collaterals, because collaterals are friable, they can perforate, whereas the vein graft are easier. This is a case where the patient had an SVG occlusion. The bypass in 96, we're in 2021 at the time. He's got a circ, a right CTO and a circ CTO, and I have no clue where it's going. So I get into the vein graft, and I get down this vein graft that's occluded, and finally, I make progression, and I find a vessel right there. And I figured out that this right sitting graft is going to the left system. I thought it was going to the right system. So finally, found an OM, got back, we figured out that it was the circ, the issue. Why was this patient so sick? We just looked, the vein graft was occluded. It's because it was a big circumflex, also giving collaterals to the right. So now this patient has a native open. Let's go back to that case that I showed you earlier about the guy that came with this OM occluded. Look at this. This is a circ at the time of surgery, and this is in 2021. You can't barely see collaterals going there. This is with the graft. You can see barely little collaterals there, but it was like big vessel. So all is shrunk. This guy is in class 3 angina. He's very symptomatic. The vein graft is occluded. We've got that big chunk of calcium right there. So we first started let's get the LED, the right open. So we started, the LED was diseased. So of course it's complex PCI. We had to rotor the LED to basically be able to get retrograde into the right. So we're here in that case, we went in the LED, took a collateral, went retrograde into the right, and with what we call a dissection reentry, we're making ways around the calcium right there. And once we do that, we then place stents and we're able to open up the vessel. That's the native artery. He did better, but at some point he started to have angina again. And you can see now that the left main is going worse and worse. He has restenosis here in that big chunk. So this is basically his coronary, and we did a bypass of his coronary within the wall of the artery. Sometimes they can have restenosis, but the data is very, very favorable. Their longer-term outcomes is less than 15%, but he fell in the 15%. So we treated that. And he has new collaterals to that OM. So we treated the right, and that right, we restented, that right never came again. But at some point, so you see, this is follow-up. The right stayed open, but now he has an occluded circumflex. And because he had that big OM, we did, again, rotational atherectomy to open this vessel. And because there were some collaterals going to that OM, we decided to try to go integrate. Again, it's difficult. What we're doing here, we're doing some what we call dissection reentry. We're actually trying to tear the layer between the intimal layer and the adventitia to navigate into the vessel. So we got the microcatheter to the vessel, and then what we ended up is searching for a little connection of a collateral, and this is what the wires we have now can do, is that these wires can actually navigate through very, very tiny collaterals that are going from the distal vessel. So you can see here, this is real-time wiring, and it got into the other side, and then afterward, it's coming back with the loop, and it's back into the vessel. So now we're able to get into the distal vessel, and we got a microcatheter advance, and then by reaching in both directions, we were able to get a vessel into the true lumen. This is the vein graft to the OM2 that has stayed open, and this is now the circ to the OM1 that's open. Now this guy is completely asymptomatic and went from 3 to 0. He's very happy that the CABG helped him several years ago, but he's also happy that PCI can save the day longer term after, in the long. But this is the reality of what we can offer to the patient. So for the future of complex, this is my conclusion, for the future of complex coronary disease, I think CABG is superior versus multivessel disease in complex anatomies up to 10 years. It's been shown multiple times. Beyond, however, is unknown. And the use of vein graft at a young age will affect the patient's native coronary artery disease. So we have to remember that. The presence of a CTO is a strong predictor for referral for CABG instead of PCI. And however, CABG, especially with SVGs, is challenging when we are addressing these patients to the surgeon because they have a very remodeled vessel. However, modern CTO PCI technique may have better acute success in these patients. I think it is a call for more arterial graft or hybrid procedures. If you can stent, if you can get the benefit of the lima and get stents otherwise, and avoiding vein graft is maybe the future of revascularization. And it's also a call for more PCI younger age, but also not doing, preserving the graftability of the patient. If you don't turn these vessels into metal where there's no need for metal, and that vessel can still be grafted, there's no disadvantage to give it a shot with PCI. SVG occlusion post-CABG is expected. Timing will vary. CABG with SVGs remain a dominant cause of CTOs, I showed you. About 20% more one year after CABG. For SVG disease, as I showed you, the treatment of the native is better than the treatment of the SVG. And SVG PCI is not really good on the long term. Post-CABG CTOs, however, are difficult. And that's the reason why a lot of operators would choose to do treatment of the vein graft instead of the CTO, because it's really more involved to open the CTO than putting a stent in the vein graft. But I showed you that occluded or patent vein graft can be opportunities as well to open the native, and that our techniques now are can be used with a very high success and low complication rate to pursue or maintain the benefits of CABG to these patients. So thank you very much for your attention, and I'll be glad to take questions.
I just need to grab the microphone from under here.
All right. Very interesting discussion there. I learned quite a lot. While we're getting queued up for questions to the audience, I'll ask one question. I think back in maybe 2009 or so, David Zhao and colleagues published a paper on completion angiography. So a lot of these patients had CABG, and sort of immediately after CABG, they had a cardiac cath to look at their vasculature. I think one of the things I remember, anywhere from 10 to 20% of the grafts already had some sort of anastomotic lesion or some issues, and this is 24 hours post-CABG. Is there any role for completion angiography in the modern era? Should we be looking earlier for some of these issues, since we know perhaps 1 in 5 grafts may have some sort of a defect that early on?
This is a very good question. Opportunity, I would say yes. Do we have the data to support this? No. I think it would have to be done in sort of a trial where people would acknowledge that this is the limitation of bypass surgery, and to maintain the benefits, you would have a group where you could do systematic coronary angiography and then optimize what is being done versus not doing it. It will alleviate the initial problems of vein graft anastomosis and stuff like that, may complete the revascularization at the beginning, but a successful vein graft will nevertheless become disease, right? So I think it's another opportunity. But I remember a case, and I saw this patient in the clinic yesterday, who had bypass recently, and the surgeon described an intramyocardial course or myocardial bridge of the LED, and also of the OM, and finally was able to graft a diagonal with the Lima and a PDA. So the OM is not grafted, and the LED neither. But I think there was no, I picked up that case as an opportunity to complete the revascularization. What's gonna happen often is that the patient will have symptoms, may have an event, come back because he's got an incomplete revascularization. But maybe I think we have a better opportunity as in cardiovascular sciences to merge forces and say, I have this. And gratefully, the surgeon at the time told us, we've had an issue, and if you think we should probably do an angiogram, please do it. So that's good.
All right, I have a question here. Often we send people for bypass surgery after we have failure of our stent work, ISR, problems with that. And then you go back in and you work on this substrate and you make it work. What will be your message to us as interventional cardiologists? Where do you see we could improve our work, or what do you do differently once the stents have failed and you're coming back post-CABG and you're treating them again?
Yeah, I think ISR deserves a full talk on itself, and there are clearly cases where it's more like a patient factor issue, neointimal proliferation, diabetes. You've got proximal ISR, and the best treatment for this patient will be bypass, especially if the distal vessels are open. But there are cases where bypass may not be the first solution. We have cases where there's grossly underexpanded stents. They can be treated. Now we have DCBs. Now we have other strategies where we can do this. And depending on the age of the patient, I always say that the golden age for CABG is probably from 60 to 75. Over 75, they're a higher risk for acute events. And lower than 60, well, they're young to get grafts. And then they will probably live longer than their grafts. And that's one of the issues. And that's, but again, I think optimal PCI is, we are all talking about this as a group of interventional cardiologists. I'm glad to have joined a group that does 100% imaging. In the US, there's 5% to 10% of interventional cardiologists doing IVUS and OCT during their PCI. This is the reality. We're at 100%. Imaging has been shown to reduce the risk of acute problems, also longer-term events. If there's one thing that can reduce mortality during stenting, is using an IVUS and looking at what you do, optimizing. So we can optimize previous work, but there will always be, cases where CABG remains the best option. And however, the younger the patient, we have to care better or more about the longer-term outcomes of these patients. Remember, our surgeons, as good as they are, as nice as they are, they don't see these patients on the longer term. We are the ones seeing these patients. And we are the ones seeing them coming back with an EF of 50 at some point, 40% down to 30, because they've been losing grafts and heart failure and everything. And that's the long term, never. So when they do 10 years in a comparison of PCI with CABG, 10 years is a teenage for a vein graft. It's like, it's a teenage. We don't look, what we see when the ones we cap that are not doing well with their vein graft, they were not grafted in 2015, 2014. They were grafted in 2007, 8, 10. So that's when it gets to the 10-year bar, that's where we start seeing a real decline in their ability to function and the heart failure and everything. And we're lacking data, but my hypothesis is when we get 10 years after a surgery, your outcome may be worse than if you'd been managed with PCI before. And get this CABG, which is like an ace of spade, to play later in the game. This is really what I think.
Thank you, Dr. Rinfret. We do have a question online, but I just want to look around the room. Is there anybody else here that has a question? Please raise your hand and I'll come to you.
Thank you, Dr. Rinfret, for the talk. I wanted to ask what your antithrombotic strategy is after correcting, maybe putting a stent in an SVG or a CTO. What is your strategy? Do you go longer than 12 months? How long should it be? And what type of, do you go for potent P2Y12 agents, or what do you do to prevent the subsequent events?
That's a very good question. We don't have specific data related to CTOs and reconstruction and stenting false lumen and stuff like that, and you're right, so that raises the question of what we should do. The best data we have is from studies where they've looked at subgroups of patients who've had more complex PCI where they would derive longer-term antiplatelet therapy. So usually my practice is to make sure that they have long-term therapy, like at least 1 year, if they could tolerate. Of course, if they cannot tolerate, it's fine. If there's one to be dropped, I prefer that the aspirin being dropped than the P2Y12. But remember that if we're dropping aspirin and keep Plavix, then it's another ball game, because if you're a non-responder to Plavix, then it's like having no antiplatelet on board. So if it's the strategy that's selected, I really want to know what is the PRU and the antiplatelet effect. So I will test Plavix responsiveness if it's Plavix that is selected for any reason, but I lean towards more potent antiplatelets in these patients and aiming at least for 1 year.
Okay, thank you. And the question online, this comes from Dr. Patel. What are your thoughts on hybrid approach, Lima and PCI of rest of coronaries?
Yeah, I think to be honest, I really think it belongs to the present and also the future of revascularization strategies. I really think that multi-arterial, when performed, has probably an edge on anything else. And but sometimes you have limitation. The radial artery is not graftable, and maybe having. I think the minimally invasive part of it is another question. I wouldn't mind having bilateral IMA being done on the left system and stent being done on the right through a sternotomy. I think in the end you would derive the same benefit. And why are we? So this is certainly something that could be explored in some of the patients. Bilateral IMAs are probably underused, and sometimes what is referred to be the problem is the infection and the dehiscence rate of the sternum, but that is usually much less than 1 to 3% depending on experience of centers. So I think, but with the minimally invasive, I think there are like great cases, and it starts with the angiographer and us to be able to identify these 3 vessel diseases that have a beautiful IMA that's likely to stay, that's likely to be straightforward. A patient who's gonna, get through an incomplete revascularization, either PCI or with the Lima first, and then afterward complete the work. The thing is that the only downside of hybrid to me is when it's being used too young, and you end up with ISR, recurrent ISR in the non-LED territory, then you've used this patient will never go to CABG afterward because he has a patent Lima. So that's some of the issues that we need to think. So I'm not a big fan of hybrid in young age. I think hybrid is a great when you get in the CABG span of life, which to me, again, is from 60 to 75, and encompass probably, 50 to 60% of the population. But here in our hospital, the population between 30 to 50 years old is humongous. So we have a lot of early disease. So that raises the question of how we should manage these patients.
Any other questions? If not, real quick, Stephane, could you just talk to us about the complex coronary disease program here and the work you guys do and how folks can get patients to you?
Excellent. Thank you so much. We're building this the plane as we fly. Of course, there's a lot of things. It's been great. There was already a complex PCI center here with Nima Ghazemzadeh and Fagan Patel and also Glenn Henry. Since I took the directorship, we're also trying to merge it with another subgroup of patients that we think share a lot of the common issues with the complex patients. So basically, the ones that are not treated either with CABG or with PCI, but are more difficult, let's say post-CABG, complete surgical turndowns, but also the open artery cases, the ones that have INOCA, the young female with open arteries. And we are launching as we speak this week, and we have our new coordinator, Lauren, who just joined us and started with us, the TRAIL program. TRAIL stands for Treatment of Refractory Angina and Ischemia for Life. And this is exactly targeted for these patients who are usually left over by traditional strategies, which is PCI, regular CABG. You will have patients that have already had CABG, they're non-surgical CABG, and you have patients that have open arteries. It's not going to be through revascularization that you're going to help them. They may have diastolic heart failure, they're going to have other things. So the TRAIL program will be targeting this. It will be, the director of the TRAIL program is Dr. Olga Taleva, who you really know, and I really know as well. And with the blessing of our director, Glenn Henry, we will be focusing on these patients. So whoever you have that doesn't fall into, let's say, your common run-of-the-mill coronary angiogram, needs a cath, go there. If you really think he's already had an angiogram, his post-CABG is complex, is this and that. Post-CABG angiograms, we're all very enthusiastic in seeing them because they have opportunities. They always have CTOs, and I think we can do good with them. And of course, people doing INOCA and MINOCA, Glenn Henry, and Olga will be very happy to see these patients as well. So the TRAIL program, stay tuned. We're gonna get more of this outside, and the TRAIL stands for also the Trails of All Beautiful Georgia here. And our objective is to put the patient back on trail. And that's what we want to do. Thank you.
All right, excellent.